Hello my dear students, I am Dr. Vaishali Bharambe. I am an MBBS, MD, PhD anatomy. I have been teaching anatomy for more than 25 years and I love it. Today I am going to talk about anatomical perspectives of uterine prolapse surgery. Now you must be wondering, what is an anatomist doing talking about uterine prolapse surgery? So understand that in anatomy department you learn anatomy. In surgical line, you learn surgery, but there is a gap between the doors of these two departments, which is surgical anatomy. And as anatomist, if we are able to take you to that point where you begin to understand the surgery easily, then that's a service we need to perform. Surgical anatomy has become an absolute necessity for students today, and that's why I have started a surgical anatomy line. A separate line where I only explain what is the anatomy needed for any surgery. For example, now at one point, maybe a couple of months back, we've discussed inguinal canal region, we've discussed anorectal region, all this from surgical point of view. With the same thought process today, we are going to discuss what is the anatomy you should know for performing uterine prolapse surgery. Remember, if you like the lecture, then the MCQs and the notes in the form of handouts are available on my website vbanatomy.com. So you can go and access them. Of course, you can watch the videos again as well, but sometimes the written word is needed by us to consolidate our knowledge. So that needed word in the form of handouts is also available. Please access it. Right. So how is this lecture going to go? This lecture is subdivided into what is prolapse of uterus and then what normally prevents prolapse. So for understanding what normally prevents prolapse, I will explain to you some basic anatomy of uterus and vagina as well as the supports, and then we will come to the last part, what is the anatomy needed for performing a surgery on the uterine prolapse. I hope you enjoy it and I hope it's a learning experience. So what is involved in prolapse of uterus? When there is a downward descent of vagina and uterus, you call it a prolapse. But the prolapse can be purely vaginal or it can be along with the uterus. Let's use images to understand. So here you are seeing that the vagina, just imagine that your cell phones are your dear friends, so let's use your cell phone. If this is the vagina, then the anterior wall can prolapse or the posterior wall can prolapse. In the anterior wall again, it can be upper part prolapsing, it can be lower part prolapsing. Same in posterior as well. So now with this, take a look. Here what you are seeing is a upper anterior prolapse. Upper anterior part of vagina is basically related to urinary bladder. So what you are seeing here is the upper anterior wall prolapsing, and thus a part of the urinary bladder begins to prolapse downwards, resulting in formation of what is called a cystocele. Okay? So it can descend to such a low point that the fluid content is not being drained completely, resulting in repeated infections. So if anterior wall can prolapse, posterior wall can also, lower wall can also prolapse. So when the lower wall prolapses, you can see that the urethra falls backwards, resulting in formation of what is called urethrocoele. So upper anterior cystocele, lower anterior urethrocoele. Similarly, let's have the posterior wall prolapsing. So if the upper posterior wall prolapses, then if you recall, the upper part of posterior wall is related to pouch of Douglas and its contents, which are the intestines. So all this begins to prolapse downwards, resulting in formation of what is called enterocele. Please pause the video, use the images to understand. Then if the lower wall of the posterior part of vagina prolapses, that is related to the rectum. And therefore, you can see here how the rectum is prolapsing forwards, and that's the rectocele. So vaginal prolapses are related to all of these. So what's a uterine prolapse then? Uterine prolapse can be vaginouterine when the vagina is prolapsing, carrying the uterus down with it, Or you can have a uterovaginal prolapse, where the uterus is prolapsing and vagina is slowly turning inside out. Depending upon types, they have further subclassified uterine prolapses into first degree, where the uterus with the cervix is remaining within the vagina. Second degree, when it's coming out of the vulva. And third degree, when the entire uterus is emerging out. So these are just degrees, but you have to keep them in your mind. Question for all of you, what is a vault prolapse? Always remember, if I ask a question, the answers to these can be shared in comment section, versus you can look for the answers on the website, where all answers will be available along with the video itself. Right. So let's revise what we've learned. We've learned prolapse, and we talked about vagina, upper prolapse, lower prolapse, posterior wall, upper prolapse, lower prolapse. So we acquainted ourselves with terms like cystocele, urethrocoele, enterocele, rectocele. Then we spoke about uterine prolapse. So now question is, what normally prevents this prolapse? What is the anatomy that supports the uterus and vagina? What is the anatomy that you should know for operating in this region? So let's come to the reality now. What is preventing prolapses? Take a look. We will quickly run through the anatomy of uterus and vagina. I am not going to teach you the entire anatomy. For that, there is a separate lecture on anatomy of uterus, which of course the link is given in description section. You can access it. Here only that anatomy will be taught which is required by you to really operate in this region. Relevant anatomy. Right. So here you are looking at uterus, which you can know is an inverted pear-shaped thick walled muscular structure situated obliquely in the pelvic region, resting on the urinary bladder and resting behind on the rectum. You know it's divided into fundus, body and the cervix. Question is, what is isthmus? Isthmus is that portion where the uterus narrows down to continues into the cervix. So that's the fundus here. That's the body, which extends down from the fundus downwards till the level of the isthmus. Anteriorly now, you can see that this body is related to a pouch called the utrovesical pouch. How do we understand this? Just take your pencil and run it upwards along the superior surface of the urinary bladder. Just at the isthmus, turn the pencil upwards, where the peritoneum is turning to now cover the rest of the uterus. Carry the pencil back. See how the peritoneum now goes, covering the isthmus posteriorly, covering the posterior fornix of vagina, and then coming on to the middle part of the rectum, resulting in formation of the recto-uterine pouch of Douglas. So anterior relation done, posterior relation done. What about lateral angles? At the two lateral angles of the uterus, as seen here, you will find attachment of three structures. Use your fingers, just spread them out. You will find attachment of three structures. Anteriorly, round ligament of uterus, posteriorly, round ligament of ovary, and in the middle, the fallopian tube. Okay. So that's all you should know at this stage. This is the lateral border. Okay. So lateral angles, lateral border. So the lateral borders are non-peritoneal. Along these borders, you will see that the two edges of broad ligament are attached, and it's related to the uterine artery. Can you imagine all this? Let's take a look at some images to help us understand. So here is your uterus. We are observing it from the side. Okay. So you can see that it has an anterior wall which is covered by broad ligament, and the posterior surface also covered by broad ligament. And then you are seeing the beautiful uterine artery curving over the ureter, which I'm sure all of you know is referred to as the water under the bridge appearance. Okay, so that's the broad ligament, that's the ureter, and you can see how the lateral border is bare of peritoneum, related to branches and the main uterine artery. At the lower part of the lateral border, you will see the relation of uterine artery crossing over the ureter. This is an important relation. We must all remember it. It's just a brief of uterine artery. Here you are seeing the common iliac dividing into external and internal. You can see that internal is dividing into anterior posterior divisions, giving rise to a number of arteries, out of which an important branch is the uterine artery you just saw. Let's understand that finally the artery will divide into inferior gluteal and internal pudendal. Please note the internal pudendal because it again curves around the ischial spine to come back and spread out in your perineal region. So noting this artery is relevant for all of us. Right. Now take a look at this image which is showing you the entire arterial supply except for the ovarian, which receives ovarian artery directly from aorta. All other branches are visible here. So here you are seeing your uterine artery. As it approaches the lateral border, it gives rise to a descending branch which is the vaginal branch of uterine. Ascending branch which runs along the two lateral borders to finally anastomose with the ovarian artery, okay, completing that anastomotic arcade. Okay. While we are at it, I want to quickly also teach you the blood supply of vagina region. So, one artery we already know, descending branch of uterine. The others are vaginal branch of internal iliac and branches of internal pudendal. See how all of them create a kind of anastomosis anteriorly and posteriorly around the vagina. So, now I have a question for all of you. What is azygous vaginal artery? Please find out. I would love to know how many of you know this little simple term. And again, as usual, share your answer in the comment section. Else look for the answer on the website. Right. So, while the arteries approach the uterus, you can see the uterine arteries at both the lateral borders here. You can see how each uterine artery is giving rise to an anterior branch and a posterior branch, forming a circular arterial arcade around the uterus. These are called coronary branches. Each coronary branch now gives rise to radial branches which enter into the musculature, which give rise to, I won't give you the details, they are available here. You can pause the video and take a look at them. Finally, basal branches and spiral branches enter in to supply the endometrium. So, what about the venous drainage? Remember that venous drainage corresponds to the blood vessels mostly, but the visceral veins in the pelvis generally form thin-walled venous plexuses around the viscera. So, you can see the venous plexus being formed here, one venous plexus being formed here. Okay. So, now let's talk about so we've done some basics of uterus. Pause, maybe get a cup of coffee for yourself. I always sit with my cup. I believe in hydration of the right sort. Okay, so what did we learn? We learnt about the uterus, its parts, fundus, body. We've not touched on the cervix yet. We spoke briefly about the blood supply, some important relations. We introduced the concept of broad ligament to ourselves. Okay, let's quickly understand what are the layers in the wall of uterus. As you can see, inside it is lined by endometrium. Outside it's made up of myometrium, which is made up of longitudinal fibers, some of which might even pass through the uterus into the surrounding region parametrium to anchor the uterus. Okay. And then that's covered by a layer of peritoneum, which we refer to, which is the perimetrium. There's a intimate attachment of the perimetrium to the underlying musculature. The perimetrium, as you are aware, stops short of the isthmus anteriorly and posteriorly goes on to cover much of the uterus, isthmus and posterior fornix of vagina to then get reflected onto the rectum. Question is, what is this parametrium? There is endometrium, myometrium, perimetrium. What is parametrium? Parametrium is a lot of fibrous and fatty connective tissue which surrounds the uterus. On either side of uterus, extending between the two layers of broad ligament. It contains the uterine arteries, veins, lymphatic vessels, nerve plexuses. All that, and it provides structural support. So, it can condense to give strong structural support to your uterus, along with being a layer through which blood supply and nerve supply traverses, reaching various individual pelvic organs. So the importance is that it is crucial in pelvic surgeries for the careful dissection to avoid damaging these blood vessels, and though not related to today's topic, it's important to remove it completely in radical hysterectomies in cervical cancer treatment. So that's perimetrium. So what did we learn? Endometrium, myometrium, perimetrium, parametrium. Right. So this is the brief of what we have discussed. That's quite a bit, and then we will move on below to the cervix. Okay. It's about 2.5 centimeter long. It's the most fixed part of cervix. That's an important sentence from our point of view. Its extent can be described as external extent, internal extent. Externally, from the point where the isthmus, the narrow portion, down to the outer lower end of the cervix, from internal os inside to the external os. We keep saying it is less mobile than the body. Question is, why is it less mobile? Is it involved in fixation of the uterus and as a support of uterus? Let's understand. So, observe in this image how the cervix seems to have a way of entering into the vagina so that between them they form a right angle. This is the cervix, this is the vagina. See how it's entering through the anterior wall of vagina, forming an angle of 90 degrees between them. So, small portion of the cervix remains outside the vagina, okay, which is supravaginal cervix, and a part of the cervix enters into the vagina and stays inside it, which is the intravaginal cervix or the vaginal cervix, right? So this is supravaginal cervix, this is vaginal cervix. Let's understand a little bit about those. So supravaginal cervix from isthmus to cervicovaginal junction, vaginal cervix, cervicovaginal junction to the external os. So now let's understand what is the cervix related to all around and why is it being discussed today. So here is where your cervix is. As you can see, it's related to the side to two important structures. We've already discussed that. Maybe I don't have to mention it and maybe you can say it yourself. Artery arching over the ureter, right? So which artery? Uterine. Which tubular structure? Ureter. They'll be present on either side, okay. It's also, so yes, water under the bridge. I'm somehow rather fond of this term and I'll end up using it too often in today's lecture. But when I was taught, these were ways in which we used to remember. We didn't have all this fancy digital medium to help us study. We had these terms, but they stuck around for a long time. So here, on the upper side, you can see that it's related to the two layers of broad ligament, and on the side here, you can see how it's supported very strongly by the McInrod's ligament and some other ligaments which I will discuss with you soon. Remember, it's also related on the side to the paracervical lymph nodes. These paracervical lymph nodes can become thickened and cause ureteric obstruction. So now what I have done in this is I have removed the uterus completely. So what you are seeing is just the floor, okay. So this is a section through the cervix, and here you are seeing from both the sides the uterine arteries bridging over the ureter. You can see that relationship beautifully here, okay, and you can see how all this is happening in close relationship to the McInrod's ligament. Please use this image well, I am rather fond of it. I feel it gives you a very good idea of what's happening in the pelvic cavity. Right. So vaginal cervix, the part that has come into the vagina. So the anterior part of this, so as the cervix enters into the vagina, it creates four spaces. Anterior space called anterior fornix, posterior called posterior fornix, and two lateral spaces seen here, the lateral fornices. I don't want to discuss this because we will be repeating it when we do the vagina. So let's just move forward with the basic understanding that fornixes are formed. Right. So in relation to cervix, uterus forms some very positional changes, which are relevant from point of view of prolapse. So let's talk about the axis of uterus. As you can see, the cervix and the vagina are seen to have an angle of 90 degree happening between them. So this is called as the angle of anteversion. V for vagina, anteversion. Similarly, if this is the axis of uterus, it forms an angle of about 125 degree with the cervix. So my way of doing this is the vagina, this is the cervix, and this is the uterus falling over it. Okay, it's a rather good way of using your hand to remember something. I believe in this muscle memories. Your brain is noting all of this. Your brain just doesn't learn with the help of words. Your brain learns with every activity you do. So if you're using your hand, this is the vagina, this is the cervix, and this is the uterus, you are not going to forget the angles, because the angles are automatically 90 degree, 125 degree. I doubt if you can increase this 90 degree to too much more, right? So anyway, so why we're discussing all this? How does it matter? Who maintains these angles? The round ligament of uterus, you can see it here, kind of pulls the uterus forwards and down, holding it in that position. And why are we discussing this? Because it prevents prolapse. The axis of the uterus and the cervix is such that it is unable to come in direction of the axis of vagina, which is required if a prolapse has to take place. So now just use your hand to make it come back, and imagine how easy it would be now for the uterus to use the gravity and slowly begin to slide out through the vagina. So this position is a strong positional way of preventing prolapse. So at this point, these are some of the terms I would like you to explore, like retroversion, retroflexion, dextrorotation, levorotation of cervix. So now let's talk about why did I keep saying that cervix is the most fixed structure. Yes, it is the most fixed structure because 3 ligaments triradiate out from the cervix into the lateral pelvic wall. Okay. So basically it's the parametric tissue which is condensed now. It's the same layer, but at some places it becomes a little more thickened and has now got its own names such as pubocervical, transverse cervical, and the uterosacral ligaments. Uterosacral in some books is mentioned as sacrocervical. So remember, all ligaments are continuous with each other and considered to be part of the same connective tissue framework, the endopelvic fascia. Now let's understand in which plane in the, pelvic floor for many of us is a mystery. Many people really don't understand what's going on. So in which plane are these ligaments? What is their relation to the pelvic diaphragm? What is urogenital diaphragm? Take a look. So here, if this is your cervix, then in this plane, just above the levator ani, is your are these set of 3 ligaments that I spoke about. Okay, let's learn about these ligaments in brief. Pubocervical, going from the cervix around the urethra and urinary bladder, anchoring onto the pubic bone anteriorly. Its pull is balanced by the uterosacral ligaments posteriorly. So now here are the uterosacral ligaments. From the cervix, okay, passing backwards, they have a pararectal course because rectum is in the middle, right? So they go around the rectum and they get anchored to the S3 vertebra of the sacrum. Pararectal course, it's going to matter later, I'll tell you why. So just remember, they are there on 2 sides, on either side of rectum, getting attached to the sacrum, balancing the pull of the pubocervical. Fine. So take a look at this image here. This is the way the uterosacrals are. You can see they are on either side of the rectum. Macken rods. Macken rods are strong fibromuscular bands going from the cervix, spreading fan-like along the lateral pelvic wall, getting attached to the superior fascia covering the levator ani muscle. So take a look. This is your uterine artery and the ureter along the lateral border of the uterus. This is the broad ligament gently draped over them. This is the levator ani covered by fascia, And this here is your Machyn-Rod's ligament, pubocervical ligament and the sacrocervical ligaments. So understand their position compared to the rest of the anatomy. And of course, sometimes the ureter may pass through the Machyn-Rod's ligaments. You have to be very careful when you are doing the dissection there. The rest of the anatomy is for you to see. This is the urogenital diaphragm and these are contents of the superficial perineal pouch. So what are the different names for Machyn-Rod's? Some books will call it cardinal, some books will call it paracervical ligament, lateral cervical ligament and so on. Machyn-Rod's ligaments can sometimes be damaged during delivery or the process of parturition. If incorrectly repaired, they can lead to prolapse of uterus. Very important to remember. So other ligaments are also attached to uterus. Since we are talking about ligaments and we are in the process of understanding the supports it has, let's run through the other ligaments as well briefly. So other ligaments attached to various parts of uterus are round ligament of uterus, attached, you remember the 3-finger thing, attached to the lateral angle of ureter, passing forwards, passing through deep inguinal ring, inguinal canal, superficial inguinal ring and attached to labium majus. What does it do? It's basically the remnant of lower end of gubernaculum causing the uterus to fall forwards and downwards, which helps to maintain the angle of anteversion, anteflexion. This is revision because we've already done this. There's a question here called what is canal of Nook? Please think about it and answer in the comment section. Other ligaments also attached to uterus are as follows. This is the broad ligament. I will be talking about it later. Now imagine from the uterus forwards on to the urinary bladder is a fold of peritoneum. What do we call that fold? Utrovesical fold. Does it support the uterus? No, it doesn't. It's a peritoneal fold. So it's not going to physically support, but of course it has its own purposes. But it's a fold that we need to know about. Similarly, from the posterior wall of uterus on to the rectum, another fold called the rectovaginal fold. And as the peritoneum creates this fold, it also passes laterally and drapes itself over the uterosacral ligaments. As it drapes the uterosacral ligaments, it results in formation of two folds which are called as the rectouterine folds. Utrovesical, rectovaginal, rectouterine. Between the rectovaginal and rectouterine, there is a fossa formed which we call as the rectouterine pouch of Douglas. So let's briefly discuss this pouch. It's the most dependent part of peritoneal cavity. So if there's any secretion, it will get collected here. Bound anteriorly, you already know, by the supravaginal cervix, posteriorly by middle part of rectum, on the side by the rectouterine folds. Okay. Now there are some dimensions given here, 5.5 centimeter from the anus, 7.5 from external vaginal orifice. Why are these dimensions given and what is going on? So here you are seeing a sagittal section through the pelvis and this is your needle passing through the vagina, through the posterior fornix into the pouch of Douglas so that any pus or blood that gets collected here can be aspirated without the necessity to open the anterior abdominal wall. So that's why this little bit of anatomy was discussed in a little more detail. Continuing with the last bit, the broad ligament peritoneum that you draped over the uterus anteriorly and posteriorly. So there are a double fold. There are two broad ligaments on the right and left. I am mentioning this because as a student I used to think that broad ligament is only one. So basically it's the same layer but described as two, one on the right and on the left. Okay. It extends from the lateral border of the uterus to the lateral pelvic wall such that the broad ligament helps to divide your pelvic cavity into an anterior pouch and a posterior pouch. Anterior pouch you already know is called vesicouterine pouch, posterior pouch which is the rectouterine pouch of Douglas. So these two pouches are formed because of the completeness of the broad ligament that is dividing your pelvic cavity. This is rather simplistic way of helping you understand it. The broad ligament has got two surfaces, antero-inferior. So you can use the mouse to understand antero-inferior, posterior-superior surfaces. Four borders: superior, inferior, medial, lateral. Self-explanatory, I'll just run through the basics here. Right. So here you're seeing the antero-inferior surface, okay, with the uterus falling forwards. Antero-inferior surface will be obviously related to the urinary bladder separated by vesico-uterine pouch. Posterior-superior surface, okay, of the broad ligament is related to the two ovaries and the double fold of peritoneum attaching the ovaries to the posterior surface of broad ligament. This is quite a bit. So let's understand. Just remember, in the anterior part, it's also related to paravesical foci. Now this is something you will understand. Okay, so we've taken a the parasagittal section. Here is the broad ligament. Okay, so this part is antero-inferior surface. This part is posterior-superior surface. This is the mesovarium, which is suspending the ovary from the posterior wall of the broad ligament. Now let's talk about the upper border broad ligament, which holds the fallopian tube, and in the lateralmost part becomes a short little fold that connects this to the lateral wall, which is called as suspensory ligament of ovary, through which blood vessels and nerves enter in to supply this region. You can see that here. I want you to focus on this. Question again, is there another name for suspensory ligament of ovary? So superior border done. Let's talk about inferior border. I won't talk about it. You already know the relation you have to remember here. The two layers of broad ligament will separate out and the gap in between an artery and ureter will be passing. Done? Parts of broad ligament. The broad ligament has got four parts to it. This whole thing is the broad ligament. You can see the part holding the fallopian tube is called mesosalpinx. Holding the ovary is called mesovarium. Below the mesovarium is called mesometrium, and the last part is called suspensory ligament of ovary, which we've already discussed. So what does the broad ligament contain? By now you should be able to tell what it contains. Won't discuss it. You can pause the video to read in case you want. But what we have not discussed, which are also contents, are the lymphatics, nerves, and a few muscles of the uterus. Also present here are some remnants of embryology. When I do development of uterus, which will be released soon, you can see that to understand what are tubules of Epoupharon and what is duct of Gartner and so on. Okay, so because it's beyond the purview of this class, of course the answers to this are also given in the notes which are displayed on the website. So feel free to access that. So one quick brief revision of what we've learnt up till now. This is the fundus, this is the isthmus and the cervix, external os. We learnt about the fallopian tube, the parts of broad ligament, mesometrium, mesovarium, mesosalpinx. Then we learnt about the suspensory ligament. Here in the image you can see how blood vessels are entering in through it. This is the round ligament of ovary and uterus, and that's it. So just this is what we've covered. For further details of anatomy of uterus, of course, please see the separate lecture which has been uploaded for further details. Right, so let's move on to discussion about vagina. Vagina, as you know, is entered into by the cervix such that its anterior wall is way shorter than its posterior wall, 7.5 and 9 centimeter dimensions, has an angle of about 90 degrees with the cervix. Its anterior wall is non-peritoneal. Upper part, this is all common sense, upper part is related to urinary bladder. Lower part is related to the anterior the urethra. Posterior wall is quite extensive. You can divide it into upper 1/4, which is related to pouch of Douglas. By now these answers I am sure are already coming in your mind. The middle part is 2/4 related to the rectum, and the lowermost 1/4 is related to the anal canal. So that's the whole vagina posterior wall we are looking at. That's it, take a look. Okay. So relations of vagina on the side will be at the top, ureter uterine artery, come below, McEnroth's ligament. I want you to use this animation well for your understanding. Ureter uterine artery, McEnroth's ligament, levator ani and the fascia covering levator ani, urogenital diaphragm, contents of superficial perineal pouch. All these are relations. Use this animation well and you will get the layered concept of pelvic floor. About the structure, I think I leave it to you to read this. Let's now come to a little bit about lymphatic drainage. Okay, so the upper part of the uterus drains into pre-aortic and para-aortic lymph nodes. The angle of uterus, however, drains into superficial inguinal lymph nodes along the round ligament of uterus. The lower part of uterus drains laterally into external iliac group of lymph nodes. The cervix drains laterally into the internal iliac lymph nodes, external iliac and obturator lymph nodes, and to sacral lymph nodes. Come further below, the vagina drains into external iliac. I am just explaining to you what is there in the image. Use the image, you don't need me here. Just remember that the lowermost part of vagina again drains into superficial inguinal group of lymph nodes below the hymen. Nerve supply is by sympathetics and parasympathetics. I want to briefly revise the pelvic floor with you before we go further. Broad ligament, McEnroth's ligament, we are going from above downwards, okay. Broad ligament, McEnroth's ligament, levator ani, urogenital diaphragm, contents of superficial perineal pouch, subcutaneous tissue and skin. These are the layers you will go from below upwards when you are trying to reach the uterus. So that's the reason why I wanted you to just go through this animation once or twice to get you comfortable. So we are now further passing down to discuss in brief the pelvic diaphragm. So pelvic diaphragm is basically two muscles together, levator ani and coccygeus. Levator ani itself has several parts to it, each of which is a part of support of uterus. So here you are seeing the sphincter vaginae, a muscle that's winding around the vagina, reducing the size of the urogenital hiatus, preventing prolapse. Here you are seeing puborectalis, which is winding around, passing around the rectum at the anorectal junction, helping to maintain that angle, again supporting the uterus posteriorly. This is pubococcygeus, iliococcygeus and so on. Many of these muscles are inserted into the perineal body, which acts like a central fibromuscular body holding all of them in the center. We will discuss its role soon. Here is the urogenital diaphragm with the contents of deep perineal pouch, and then below that, which is bound above by the superior layer, below by the perineal membrane, and inside by the contents of deep perineal pouch. So quickly the perineal membrane. Here's the pubic symphysis, here's the perineal membrane, which you can see thickens anteriorly to form a transverse perineal ligament. As it passes posteriorly, it's attached to the perineal body. It divides into two layers in this manner. One layer passing upwards to form superior layer of urogenital diaphragm, other layer passing downwards to become continuous with Colles fascia. The upper compartment thus formed contains the deep transversus perineae, and the lower compartment contains the superficial transversus perineae. In between the transverse perineal ligament and the pubic symphysis itself, you can see here the deep dorsal vein. So now we are looking at perineal membrane from below. This is the perineal membrane, and you can see the female urethra and the vagina passing through it, and it is being pierced by a number of very important blood vessels and nerves. What are these blood vessels? The dorsal clitoral artery and nerve, deep artery of clitoris, artery of bulbs of vestibule, posterior labial nerves and vessels. I have given you this diagram. You can of course come back and revise these blood vessels here. Here is the perineal body, which is a point where all these muscles are getting attached. I always like to think of perineal body like a blown up balloon with the tie below it, okay. So now just imagine that were you to go with a scissor and cut off the tie of the balloon, the whole balloon is going to open out, right. Similarly, the perineal body is holding everything together in the center. You damage it and the whole thing opens out. If damaged during childbirth and improperly repaired, urogenital hiatus becomes enlarged with resultant slow prolapse. So I want all of you to imagine that you are holding a ball now in your hand, okay, and the junction of your fingers is your perineal body and the ball is in your hand. The moment the junction becomes loose and your hands separate out, the ball is going to plop down, which is exactly what happens where there is a uterine prolapse in relation to a weakened perineal body. So contents of the deep perineal pouch, through this pass your urethra and vagina, sphincter urethrae, transversus perineis profundus, a lot of important blood vessels and nerves which we have discussed, and below this you will find contents of superficial perineal pouch. So a lot of anatomy, some of which I literally feel I have dumped on you, but let's put it together by classifying these structures as supports of uterus now. I won't be discussing everything again, just helping you to put it together. There are some structures which will act as mechanical supports, some which will act as positional supports, some which will be muscular supports, and some others which will be just surrounding there, staying there to support, okay. So there's a separate lecture on supports of uterus which gives all of this in much detail. Please feel free to access that to learn more. In mechanical supports, remember the ligaments that we talked about, the true ligaments, the pubocervical, the uterosacral, the McInrod's are effective. Positional supports, you have your round ligament. Again, for one last time, the action of vagina, cervix and uterus falling forwards, maintaining the angle necessary for preventing a prolapse. So this just to tell you what happens when the uterus just retroverts, how retroversion helps to straighten the angle and therefore assist in prolapse. Muscular supports, we've discussed perineal body. I want you to just look at pubovaginalis and puborectalis here. Here's the pubovaginalis muscle. You can see how as it winds around the vagina, it's going to narrow the hiatus urogenitalis, preventing prolapse, constricts the vaginal opening. In the second case, you are seeing the puborectalis. It's forming a sling around at the rectoanal junction, and you can see how it helps to maintain that angle of the rectum and anal canal. So the wall, the posterior wall of uterus is literally leaning backwards on this angle, okay. So the posterior wall of uterus and vagina is being supported by the anorectal junction. Never forget the use of parametric material, which is packing material supporting everybody from below. The urinary bladder acts as a physical support anteriorly. Posterior wall of vagina is said to have a thickening on it, which is called as the cervical cushion. The cervix goes and rests on it. You see how everybody is oriented towards preventing a prolapse. Even the vaginal wall itself thickens to support cervix, trying to prevent a prolapse. Parametrial packing material, beautifully seen in this image. I want you to pause and take a look at it. It just packs up everything that is empty, supporting. And cauda vasculaire. Now this is something which we don't discuss much, but the whole vascular network that comes in and to supply the uterus by itself forms a strong support. Finally, what did we learn today? We learnt about what is prolapse. We learnt about what is the structure of uterus and vagina. What are their supports? What is the anatomy needed for surgery for prolapse of uterus? I've given you a lot of material. I want you to go back to some of them, sit and ponder upon it. All these, each of them needs detailed discussion, but are beyond purview of this given time in which I must create my video. I can of course make it several hours long, but I know for a fact that you won't watch it, and I want you to watch it, isn't it? So I hope that this lecture has helped you to understand and maybe will at least help you to enter into the OT or answer your Viva questions in Obs and Gynae with a little more confidence. Feel free to put down your comments in the comment section. I would love to try and answer your questions or alter some of my notes in response to your comments. So feel free to comment. Please like and subscribe if you like the video. I'll see you across the screen in some other surgical anatomy video. Thank you.